Hello, good evening, everyone. Dear colleagues and friends, it gives me a great pleasure to welcome you and thank you for joining us in this webinar. This webinar is on ALS, amyotrophic lateral sclerosis. It is one of the educational activities of the Emirate Neurology Society, and the credit goes to Dr. Sohail Al-Rukn, the president of the society, who's organizing such meetings. This webinar is sponsored by Biologics, organized by the MCO, and endorsed by the EMINS. Thanks for all for their contribution. The title of the webinar is Understanding ALS, from Disease Course to Clinical Trials. And tonight we will identify the various clinical trials and we will discuss the latest updates on ALS genetics and molecular roots. This is an interactive webinar, so we invite you and we encourage you to submit your questions at the Q&A button icon. You see it at the bottom of the screen, and the speaker will be more than happy to address your questions. This webinar is semi-accredited, and the MCO, the organizers, will notify you by email at the time to get, or when you will get the certificate. And now it's my great pleasure to welcome and introduce our distinguished guest speaker, Dr. Anne-Marie Hubers. Dr. Hubers is Associate Physician at the Neurology Department of Clinical Neurosciences in Geneva University Hospital, Switzerland. And Dr. Huber will be talking about understanding ALS from disease course to clinical trials. Dr. Hubers, please, the virtual floor is yours.
Good evening. Thank you, Mr. Chairman, for your kind introduction. Thanks to everybody for having me. It's a great pleasure to talk talk tonight, and I will now share my screen. So I'll talk about 50 minutes plus minus, and I'll be talking about the basics of ALS from disease course to clinical trials. So in general, there can be central nervous system and peripheral nervous system lesions. Obviously, in different conditions, you have different kinds of disease or of lesions. And in the classical ALS, which is an affection of the central and the peripheral nervous system, you may have on the one hand a central spastic paresis due to lesion of the first motor neuron, and a flexed paresis due to ventral horn lesion or nuclear lesions. So if you look at this scheme of the motor unit, in general, motor neuron diseases are located really at the body of the neuron, at the core of the neuron, whereas mimicking diseases, especially peripheral neuropathies, are located on the axon. And then, of course, you have all the lesions related to muscle diseases, like, for example, myopathies, or lesions of the neuromuscular junctions, which might be, in general, myasthenia gravis or Lambert-Eaton syndrome. Clinical features of ALS include generalized wasting and fasciculations of facial or limb muscles, a bulbar involvement that is involvement of swallowing and tongue muscles is common. And these peripheral paresis may be associated with upper motor neuron signs and symptoms. And as you all know, unfortunately, this is an aggressive, steadily progressive condition which is fatal at the end. How may motor neuron diseases present on the clinical level? You may have, or the patient may show just a selective loss of lower motor neurons from pons, medulla oblongata, and the spinal cord, together combined with upper motor neuron loss originating from the brain, from the cortex. And the clinical picture obviously varies, can vary quite widely, depending on whether there's more upper motor neuron or more lower motor neuron involvement, which muscles are involved, and the rate of cell body loss on the neuropathological level. So if you just look at the motor neuron, here is this this scheme showing the first motor neuron on the one end of the spectrum, and the second motor neuron on the other end of the spectrum, with primary lateral sclerosis representing a classical disease involving mainly the upper, or almost exclusively for a very long period of time, the upper motor neuron, and as a typical representative of solely affection of the lower motor neuron, you may find progressive, so-called progressive muscular atrophy. And in the middle, you have the classical amyotrophic lateral sclerosis with affection of both the upper and the lower motor neuron. We also distinguish between different onset types. Around 70% of patients show what we call a spinal onset. So disease onset with paresis on the region of the limbs. And around 30% show disease onset in the bulbar region. So swallowing muscles, tongue muscles, etc. For central paresis may present on the clinical level as increased reflexes, as increased tone, muscle tone, increased muscle tone, which leads to spasticity, which can even be painful, and pathological reflexes like the Babinski sign, which signifies a dorsal flexion of the big toe after scratching of the lateral face of the foot, or dorsal flexion after scratching the shin, which is called Oppenheim sign, or dorsal flexion again after pressing the calf muscle. And all these signs are pathological reflexes pointing towards a lesion in the within the pyramidal tracts. On the other hand, peripheral paresis, which is paresis related to the second motor neuron, may present with decreased or even lost reflexes, a flaccid, weak tonus, and muscular atrophy, like you can see here. This is a very good example of what we call a split hand syndrome. It's a very classical sign of lower motor neuron affection in ALS, and it's called split hand syndrome because you see the atrophy of the first dorsal interosseous muscle, while the other hand muscles, and especially the hypothenar, are quite preserved still. So I already mentioned lots of different motor neuron diseases. There's a whole spectrum, obviously, of motor neuron diseases, and ALS is just the most common and the most, well, classic of them. And as I said, ALS in general affects the first and the second motor neuron. First motor neuron diseases may be, for example, primary lateral sclerosis, which after a long period of time, 10, 20 years, may then evolve into ALS via affection of the second motor neuron, whereas hereditary spastic paralysis or paraparesis affects only the first motor neuron. And as the name implicates, this is a genetic disease. On the other hand, the second motor neuron, classical motor neuron diseases affecting only the second motor neuron are, of course, spinal muscular atrophy, the most common motor neuron disease in children, or spinal bulbar muscular atrophy, or the so-called Kennedy syndrome, a genetic disease affecting mainly the bulbar muscles on the level of the second motor neuron. I mentioned the regions of onset. So 1/3 of patients show disease onset in the first or bulbar region, about 1/3 in the so-called cervical region, which is the upper extremities, only 2 or 3% in the so-called thoracic region, which is obviously the trunk, and another 30% roughly in the lower region, in the lumbar region, which is the legs. For this study, we included 700 ALS patients, and we found that on the clinical level, there seems to be something like a distinctive spreading pattern, which is characterized by onset of the disease in the distal muscles, like you can see here in the hands or in the calf muscles, and distally, the extensors are more severely affected than the flexors, whereas when you look at the proximal muscles, so at the limb girdles, the flexors are usually more affected than the extensors. And that's where you find this classical picture of an ALS patient who might, at the beginning, only present with an isolated foot drop without any pain or anything related. And that's often why these patients, and only in the evolvement of in the disease course, you may see that other muscles are affected in a more general manner. And that's also one of the reasons why this disease is still so difficult to detect and to detect early. Let's see whether the video is working, but it should. Okay. So here you can see a patient with a bulbar onset of the disease. You can see fasciculations and atrophy of the tongue, as well as this hypomobility of the tongue. And you also see an increased masseter reflex as a sign as a first motor neuron sign in the bulbar region. Here you see fasciculations on the region of the chin, even if the patient doesn't open the mouth. So second and first motor neuron signs all in the bulbar region. Regarding genetics, it's still the main percentage of patients represent what we call sporadic ALS. Around 5 to 10% of all patients are diagnosed with a familial or genetic ALS. And in these patients with genetic ALS, the peak onset of the disease is generally younger, at around 47 to 52 years of age, whereas in the general population, patient population, disease onset is at around 70. Peak of disease onset is at around 70 years for sporadic cases. And as I said, it's a fatal disease, it's an aggressive disease with a lethal outcome after around 3 to 5 years only, and death is typically due to CO2 retention due to weakness of trunk muscles, respiratory muscles. ALS has first been described by Charcol in 1873, and that's also the reason why in French-speaking countries the disease is often called Charcot's disease. And he described a symmetric sclerosis of the lateral tracts in the spinal cord of patients, and that's where the name comes from, amyotrophic lateral sclerosis. On a macroscopic level, you can see that the anterior spinal nerve roots seem to be kind of shrunken and also grayish in appearance. On the muscular or on the pathological level, so here you have a normal muscle with the motor units being innervated by 3 different axons of one nerve. And what happens if one axon degenerates? So there's denervation and atrophy, for example, in this motor unit A, and after a couple of weeks, weeks or month, the neighboring axon may overtake partially the functioning of the degenerated axon via so-called collateral sprouting. On the neuropathological level, the disease is characterized by loss of motor neurons, obviously, but also astrocytosis, which is some kind of inflammation in spinal cord, brainstem, and motor cortex. And also motor neurons in the pons and medulla oblongata are frequently involved in the disease process, which leads to bulbar symptoms. Here you can see the picture taken out of an important neuropathological work that has been done by Johannes Brettschneider and Heiko Brag. As you probably know, you find pathological TDP43 accumulation, so that is a misfolded protein, in over 90% of ALS brains. And Heiko Braak could show that you find these accumulations not only in the motor cortex, but that they spread really via stages over very large cortical, and even subcortical areas, showing that this is really not only a motor neuron disease, but effectively a multi-system degeneration. For the clinical approach, differential diagnostic effectively bases on the EMG, so the needle myography that you can perform in the different regions I mentioned. And what you see in a denervated muscle, as I told you, as I mentioned before, due to degeneration, you will find what we call pathological spontaneous activity. So even if the muscle itself is at rest, due to degeneration, you find motor units that are expressing action, even if they shouldn't. And in the later course of the disease, via collateral sprouting, you will find large and polyphasic, so deformed responses of the motor units. So this is for the second motor neuron, or for the peripheral nervous system. You can also examine the function of the central motor neuron via transcranial magnetic stimulation. Here you see Anthony Barker, who presents the first magnetic stimulator in the 1970s, I think so. And since then they haven't changed a lot, because the technique is simple but very effective. You stimulate the motor cortex via a coil. In this coil there's a magnetic field. This magnetic field induces then an electric field in the motor cortex, and via this electric field motor neurons can be activated, and with this the physiological response of this activation of the motor units of the motor neurons, can be recorded at the level of the muscle, like for example the hands or also the legs. And with this you can quite well measure or examine the integrity of the first motor neuron or the corticospinal tract. Since a couple of years, there has been discussion about involvement of the corpus callosum in ALS, and new or modern MRI techniques like diffusion tensor imaging could show effectively that the motor part of the corpus callosum is affected in ALS. And with a double pulse transcranial magnetic stimulation protocol, you can also study the cortico-cortical connectivity, or the integrity of the neurons connecting both motor cortices. Motor cortices, and here we could show that in ALS patients, effectively, there is a decrease in this functional connectivity of the interneurons connecting both motor cortices. So here we measured what we call interhemispheric inhibition, which is a good marker for the functional integrity of these interneurons. And here you can see this is a curve of normal controls. If you increase the intensity of the stimulation, the inhibition of the interneurons increases as well until it gets like to a kind of a platform, a steady state. And this is what we see in ALS patients. So ALS patients seem to exhibit almost no intercortical inhibition, showing us that they have a severe dysfunction not only of the descending motor neurons, but also of the connection between both hemispheres. Just some words about possible biomarkers. There has been a nice paper published in JNP in 2016, showing that so-called neurofilaments in the CSF can distinguish between ALS or MND here on the left and MND mimics, and even the level of these neurofilaments might predict disease progression. Here you can see month to death or the survival curves of different patients with the highest level of neurofilaments showing the most aggressive disease course. Luckily, we know that we don't have to necessarily check these biomarkers only in the spinal fluid. We can also check them, which is much easier, of course, for the patients, in the blood. I mentioned before, and I think this is very important to understand or to know, that ALS really is not only a disease of the motor system. Around 5% of patients show a real full-blown frontotemporal dementia in combination with their motor neuron disease. But frontal signs, so frontal executive dysfunction signs, may be found in over 1/3 of all ALS patients, especially in patients with bulbar signs. And I always show this quite beautiful picture, I think, from Van Ees, from a Lancet publication, where you see really the classical ALS or motor neuron disease with upper and lower motor neuron signs on the one end of the spectrum, and the FTD, classical FTD, with all its variants on the other end of the spectrum. But in the middle, there's lots of different variants of motor neuron diseases mixed with frontal deficits. I wanted to discuss some rather rare variants of the disease with often a better prognosis, like, for example, the so-called flail arm syndrome or flail leg syndrome. And these syndromes are characterized by paresis and atrophy of the limbs. And I mentioned spinal bulbar muscular atrophy type Kennedy, which is a rare genetic disease you only find in men. And finally, primary lateral sclerosis. I mentioned this before. This is a first motor neuron disease, which shows a very, very long disease progression over decades. Here I show you an example of a patient with the so-called flail arm syndrome. So you see these atrophy of the shoulder girdle, but also of the limb muscles, with mainly lower motor neuron signs, which is atrophy, flaccid tone, and fasciculations. Because this is a kind of an atypic presentation of, maybe an atypic presentation of ALS, we could show that a lot of flail arm syndrome patients are in fact at the beginning not diagnosed correctly, most of them being diagnosed with a multifocal motor neuropathy. The disease course is atypical, being a little bit better or less aggressive than the classical ALS. Here you see the survival curves of flail arm syndrome patients in yellow and classical ALS in gray. I mentioned primary lateral sclerosis several times, so we don't have to go into this into very much detail. Just to mention that antispastic therapy may show inconsistent effects. You can try in PLS patients to you can have a try with L-DOPA. L-DOPA. They might show slight bladder dysfunction, and also the dorsal spinal tracts can be affected, which makes it difficult sometimes to diagnose this disease correctly as a motor neuron disease. In the second part of my talk, I would like to discuss treatment options and recent studies on treatment in ALS. In the 19th century, Charcol said therapeutic options to treat ALS are lying in the future. And he was right. It was only in the 1990s when Riluzole was discovered, and has since then been for a very long time the only drug that has been authorized because it slows the disease progression. It has anti-glutamatergic effects against exotoxicity, and it is also a free radical scavenger and thus has antioxidative effects. And finally, it can also have some membrane stabilization effects and thus reduce cellular energy demand. It increases the probability to survive the first treatment year by 6 to 12%. There's a wide range because this really depends on the study. An early treatment with Riluzole slows the decay of motor functions, and the prolongation of life has been shown to be around 6 to 20 months. And this is also there's also a very wide range. So 6 to 20 months, it's a quite wide range, because there might be a bias in the first studies that were performed, as there was a huge pre-selection of very specialized centers where patients were diagnosed early, and on the other hand, were being taken care of or were being taken care of at the very high level. And since for a couple of years, there has been a new kid on the block, which is Edaravone or Radicava, which is a free radical scavenger. And it has been approved in Japan since 2011 for the treatment, for the post-treatment of acute ischemic stroke, but it has never really been in use in Europe or the US until a phase 2 study showed a reduction of one marker of oxidative stress and an effect on the ALS-FRS in ALS patients. And one first phase 3 study after that showed a significant effect on ALS-FRS in a post-hoc analysis with a subgroup of quite well-defined patients. So this was the pivotal phase 3 study. And I mentioned that the effect was most prominent in a very special or very well-defined group of patients. These patients showed, of course, a definite or probable ALS according to the revised ALS-clinical criteria. They showed a score of at least 2 points or more on each of the ALS-FRS items. So just briefly, the ALS-FRS is a 48 point clinical scale, and you 48 point clinical scale. The maximum would be 48 points, which investigates different motor functions like swallowing, walking, eating, dressing, turning in bed, etc. And the minimum score you can have on an item is 0, and the maximum score is 4. Patients also had a normal respiratory function, and patients had were still early in the course of their disease. So the medication really seemed to work best the earlier it can be introduced or can be started. So here's the study design. First, so randomization was preceded by an observation period in which over 12 weeks the slope of the ALS-FRS, so the degradation in the ALS-FRS was calculated. Then patients were randomized, double-blind, placebo-controlled over another 6 cycles with either Edaravone or placebo. And the primary efficacy endpoint was a change in the ALS-FRS after 24 weeks. To mention that patients in both groups, had been either on a stable dose of Riluzole before inclusion in the study or on no Riluzole at all. Here's the dosage and administration scheme. It's a little bit complicated. So as I said, it's IV. Patients receive 60 milligrams IV daily over 14 consecutive days in the first cycle, and in the second cycle over 2 times 5 days. So for example, Monday to Friday, and this also every 4 weeks. So this is a month with a 2 weeks drug-free period in between. So these are the baseline characteristics. As I said, most patients were effectively taking riluzole on a steady level, and the patients in the placebo and in the Edaravone group were quite well matched regarding age and initial symptoms, and also the ALS-FRS. Here you can see the results. So yellow is placebo and blue is the Edaravone group. And after 24 weeks of the double-blind study, patients in the Edaravone group showed a better ALS-FRS score than patients in the placebo group, which means around 30%, about 1/3 less physical function loss in the Verum group compared to placebo. Here you can see it's just a little bit a different kind of showing, presenting the data. This is change of ALS-FRS score from baseline to the end of 24 weeks. These are the placebo patients, and as it is a progressive disease, no patient would really show a better score over these 24 weeks, and most patients show a decrease in the score of 4, 5, 6, or 3 points after 24 weeks. And here you can see the Edaravone group in blue, and you can clearly see that there is some kind of shift towards a slower disease progression in the Edaravone group. And if you if you split the ALS-FRS and only look at bulbar symptoms, fine motor function, and gross motor function, you can see that Edaravone performed well in all of these subdomains. So black is Edaravone and gray is placebo. This is the decrease in ALS-FRS, in the ALS-FRS score. Regarding safety, it looks like Edaravone is actually quite safe. Most patients reported adverse events, but adverse events were evenly distributed in the Edaravone group and in the placebo group. It seems like the most common side effects are actually related to either the natural disease progression or to the fact that this is an intravenous application, which might cause at some point inflammation of the peripheral vascular system, with even spreading inflammation and fever. And in the post-marketing, okay, this is this, and now I would like to mention also the open label extension study. So as it is an open label study, all patients were switched after these patients receiving placebo were switched to Edaravone. Patients that had already been under Edaravone continued receiving Edaravone over another 24 weeks. And so these are the patients that had not been switched, and these are the patients that had been switched from placebo to Edaravone, and around 30%. We found a 30% between group difference that was maintained at the end of cycle 12, favoring actually patients that were initially already assigned to Edaravone, and also speaking in favor of an early treatment start. Adverse reactions, again, coming also from the open label study. As I said, lots of adverse events related to normal disease progression. There's also always this, the study mentions contusion without really explaining, in my view, what this means. I think it means falls, and then contusion after falls, but I never really understood what this actually means. So, but there's gait disturbance and falls, or contusion, a little bit more common in the Edaravone group than in the placebo group. But in general, adverse events were more or less evenly distributed in both groups, even a little bit more frequent in the placebo group. Maybe important to mention that in the post-marketing phase, some allergic reactions have been reported, mainly, which have never been life-threatening, mainly during the second or the third cycle, not during the first one. To finish, I would also like to again mention that it's not only medical treatment or pharmacological treatment that helps ALS patients and that increases their survival. We know that, for example, non-invasive ventilation can be very helpful to increase survival, as we know that patients that show a vital capacity of under 60% show a significantly decreased survival time. Here you can see the survival curves. This is vital capacity above 60%, and these are the patients with a vital capacity of 60% or lower. It's the same for the body mass index. Patients with a low body mass index, here in red or in black, show a decreased survival probability compared to patients with a body mass index of higher than 25 kilograms per square meter. So it is important to educate the patients early in the disease, to maintain their weight, and if it's necessary, to even implant a percutaneous endoscopic gastrostomy sonde to maintain the body weight. So to sum up, there are two medical treatment options that are authorized at the moment in the US and in Switzerland, but not in Europe, which is Riluzole and Edaravone. Riluzole orally and Edaravone IV. And supportive treatment is very important, such as invasive or non-invasive ventilation, if necessary, percutaneous antral tube feeding, treatment of cyalorrhea, treatment of pain, etc., physiotherapy, logotherapy on a regular basis, and a high-calorie, high-fat diet. And with this, I finish my talk, and I thank you again for your attention, and I'm now open to answer any questions. Thank you.
Thank you, Professor Hubers, for this excellent presentation. There are 4 or 5 questions in the Q&A box. So we have something like 10 minutes to cover these questions and other questions. So the first question is, how is the CPK levels in ALS?
It can be mildly elevated. So that means at around between 200 and 400 in this range. It can also be normal.
Okay, great, thank you. The other question, patient of ALS is very rapid calorie burning and mostly they are malnourished. Would you please throw a light on this mechanism?
Yeah, it's a very interesting question. At the beginning, we long time we thought that the weight loss is mainly due to muscle loss, but recently there have been studies on the hypothalamus in the mouse model of ALS, pointing towards a more generalized metabolic disturbance or disequilibrium in ALS patients. And of course, the fact that they might have at some point of time swallowing difficulties is one important factor that may lead to caloric deficiency. We also know that a high fat diet, rather than, for example, a high protein diet, is protective in the disease course. We don't know exactly why.
Okay, great. We have 2 more questions. One is ALS complete curable or not?
Well, no, unfortunately, no. No, I mean there are promising. There are very promising studies for genetic ALS. I didn't go into that, but there's one medication, an antisense oligonucleotide for patients with an SOD1 mutation, so the second most common mutation in familial ALS. This might be a promising start to cure ALS, but let's say the normal ALS, the sporadic ALS is not curable at the moment. In contrast to, for example, spinal muscular atrophy, so a very common motor neuron disease in children, where we have now genetic treatment options.
Thank you. I just attended a lecture on ALS in the European Academy of Neurology, just 1 hour ago. And they were telling that diagnosis is delayed in most of the European countries. 45% of cases are delayed about 9 to 11 months.
Yeah.
Even by the neurologist.
Yes, that's true.
How is it in your institution? Is it like this? The cases coming to you are delayed usually?
So, I mean, of course, we are a specialized muscle center. So in our institution, the delay is less, but still it is around, I would say, until I see the patient to post the diagnosis, I would say it's still 3 to 6 months, which is okay still. There have been new diagnostic criteria being proposed in, I think, 2019, mainly by the Ulm group, that really focus on this idea of trying to decrease the diagnostic delay by, for example, including genetics or frontal deficiency into the diagnostic criteria.
Okay, thank you. You mentioned about the neurofilaments. In multiple sclerosis, we use the neurofilaments as prognostic factor because in progressive MS, the serum and CSF filaments can be elevated.
Yes.
There's one question here about, can ALS be inherited? You just mentioned something about genetics.
I think we skipped one question.
I'll go to it later.
Okay, I'm sorry. Okay. Yes, as I said, so it's 5 to 10% where we know the genetic background. Might be more, but we don't screen. If maybe we miss some patients, but in the general population, it's 5 to 10%. I really suggest to screen, especially young patients, even if the familial there's no family history. It can be really useful to screen, especially young patients, so which is under the onset age 50 years or younger, and also patients with a very aggressive disease progression.
Okay, great, thank you. These two drugs you mentioned, we are using them in our hospital. We are using Radicava. We have 2 patients using it for 2 years, and Riluzole more than 15 years. We have many patients, they are still alive, but they are on ventilator, palliative care, tracheostomy, PEG, and they are ventilatory support. And we know the story of Stephen Hawkins. I think he survived 60 years after his diagnosis with the advanced technology, support, and these things. It seems you are interested in some of questions here. I can read for you. So which one you want, Professor Hoopers? The respiratory? Okay. Okay. Degeneration of respiratory innervation occurs in this condition. Is ventilatory treatment, and does it have good prognosis with non-invasive ventilation? I can't understand exactly. So if patient improve with ventilation, is it a good prognostic sign? You see the question here?
So of course, I mean, patients are regularly screened for respiratory failure or respiratory function loss, even if they don't show any clinical signs or don't remark any clinical signs. And if you introduce non-invasive ventilation, you can first increase the quality of life of patients because they might sleep better, for example, are less tired during the day. And you also can prolong the disease course. It's the same for non-invasive, for invasive ventilation, obviously, but this is a cultural, also I think a cultural discussion. I have the impression that in Northern Europe, patients rather tend to not go for invasive ventilation, whereas in the UK, for example, patients are often invasively ventilated. I wonder what it's like in your country. I'm interested. So do you have lots of patients that are invasively ventilated?
Yeah. Most of the patients, they reach a stage, they require ventilation. Mm-hmm. I remember one of my patients, she remained on ventilation for 16 years. Mm. She died from sepsis. Currently now we have one patient on ventilation. intubated, tracheostomy, and big. He's now 12 years. He's young chap, and he's fully conscious, oriented. But yeah, so we go for ventilation. We don't. I know in some countries, the patient has the right to say, "I don't want to be ventilated."
Sure.
Right? But here we don't have this issue. A patient comes with respiratory failure, has to be ventilated.
Oh, I see. Okay.
Yeah. And we don't disconnect ventilator support. I don't know what's in your country. The patient has the right not to be ventilated.
Of course. So we discussed this quite early in the disease course, and most of the patients they make kind of a testament saying they don't want to be invasively ventilated. It's very common. It's very uncommon that they are actually invasively ventilated. Interesting. Yeah.
And if you ventilate them, you'll go to the court.
Yeah.
If we don't do, we will go to the court.
Yeah,
there's one question. Yeah, there are different protocols, different cultures. And, there's one question: what triggers ALS disease, and how long can patient live with ALS?
Yeah, I mean, as I said, there's a wide range of motor neuron diseases, and also ALS is it's a wide range of show a wide range of clinical pictures. Actually, I mean, there are these studies showing that the median survival time is 3 to 5 years, but it can vary really, and we don't know what triggers ALS. We don't know whether there's a trigger. There is some positive correlation with smoking, but it has never been really proven. And there are some reports on a correlation with certain but very special bacteria, like for example, you find them in Guam. So this has been, but this is a very apparently there are some reports on patients in Guam or in Florida where they have lakes with a special kind of cyanobacterium. But this is really, it's very speculative.
Yeah, you know, the American Academy meeting, which was in April, they presented data about toxic environmental elements plus the genetic mutation of ALS. And interestingly, they reach in certain states, it's highly endemic with ALS due to exposure of certain lead, as you mentioned, heavy metals, environmental, culture, agricultural, pesticide. So they categorize some countries at low risk of ALS and high risk of ALS. So the high risk were fully contaminated areas, what you mentioned, lead, pollution in the environment. So there is some toxic element, heavy metals, environmental factors identified through epidemiological studies.
Yeah, but I mean, I would be interested in this study because if the heavy metals have been around for decades, and I recently read a study where they showed that there's no link really. So it's always it's difficult to say.
Yeah, the causal is not clear, but I have this on my desktop. I can email it to you if you like.
That would be great. I would really appreciate that.
Yeah, sure, I'll do. It's actually detailed study about, which was surprising to me, because you know about the Guam high incidence and high progress and so on. There's one question here from Dr. Mona. Can this drug be used for PLS or bulbar onset? I think she means Radicava.
Can Radicava be used for
PLS or bulbar onset ALS?
So for bulbar onset, it's great because these are aggressive patients, and you can really slow down the disease progression because it's so steep. The slope is so steep. For PLS, I wouldn't suggest it because PLS really is like, as I said, can take 20 years slowly progression. I think there's no use of Radicava in PLS.
Advanced case of ALS. There is one question here. There once a viral challenge, that so-called ice bucket challenge, in order to raise awareness about ALS. In the panelist opinion, how far the relevance of this challenge to spread awareness among community?
I don't know. I mean, in the community, of course, the disease was known, but I have the impression that it spread awareness in the general population. That's true. Yeah.
Yeah, actually, we, the neurologists, we don't like to make this diagnosis because you mentioned this is a fatal disease, though some of our patients survived on ventilation for 10, 15 years, but we hate to make this diagnosis. I wonder if we will scare the community by symptoms of ALS, then anyone who's choking or having cough will start thinking this is his disease. I don't know, for rare disease, better not to make awareness among society. Maybe among neurologists would be okay. The medical community can be aware.
True. I think so too. Because we see more and more patients, I guess you as well as me, who show some fasciculations, benign fasciculations, and then they worry that it might be ALS, and it's very difficult to calm them down at some point of time.
Yeah. I saw in my life something like 25 patients with ALS. It's a rare disease. Maybe few are alive, majority died at different ages. The youngest one was 28 years old, who was exposed to jellyfish bite in the sea. And repeatedly. So this confirmed the toxic theory, actually, one of the theories of ALS. And it was confirmed in UK, and he died with respiratory failure. One question here from Karim: what is the role of steroid in ALS?
Oh, there's no role of steroids in ALS.
Okay, very short answer. Thank you. Any studies on stem cell therapy?
There are studies on stem cell therapy. They are still a little bit in the still in baby steps. Let's say baby shoes. Stem cells might be a promising target for ALS. The problem is that there has been a lot of how do you say, a lot of misconduct with stem cell therapies, meaning that patients went to, for example, Eastern Europe countries and paid thousands and thousands of euros, 20,000 of euros, for some kind of obvious, not unclear stem cell therapy. So it might be a good option, but it has to be really regarded with caution.
Okay, thank you. Maybe the question before the last, is ALS related to age? Is it age related?
Yes.
You just mentioned about the
age or AIDS? To age.
Age. No, not AIDS. Age.
Yes.
How many years old?
Yeah. So it's a neurodegenerative disease of the aging nervous system. So as I said, classical ALS onset is around 70. So it's a disease of the older population.
Yeah, I think ALS is spectrum disease, isn't it?
Sorry?
ALS is a spectrum disease.
Yes.
I mean, we have many variants. You mentioned the upper limb flail and PLS, and we are about to finish. We have one question only. You mentioned you screen the family of patient with ALS. You mentioned that there's genetic predisposition. So if you have a patient with, and we identify the gene, do you screen the family for better diagnosis?
This is a difficult question. It's a difficult question to answer. So,
okay.
Well, I can answer it, but it's difficult.
Yeah, right.
So we might suggest it to the children if we find a gene. But first of all, of course, the children need to be major, so they can't be under 18.
Okay.
And you need to. I mean, you need to explain to the children the use and non-use of genetic testing. You can't just screen them. It's really up to them to decide whether they want to be screened or not.
Okay, thank you. Last question, I promise. Can ALS be prevented based on the environmental factors if you move from high risk area to low risk area?
Probably no. I mean, it's not like MS where we have this obvious where we think there might be some kind of early modulation of the immune system, and then there are high and low regions with high vitamin D or low vitamin D. The only thing we can maybe suggest to patients is stop smoking, but this is always a good option for any kind of disease. On the other hand, no, apparently you can't really. You can't.
Okay, this is the last question really. Are there any early diagnostic method of ALS that we could predict in early pregnancy? ALS and pregnancy?
So you mean are there any early diagnosis of ALS?
Are there any early diagnosis method of ALS that
I see. So you want to
maybe the fetus?
If the fetus might well, the answer is probably no.
Yeah.
No, the answer is no.
Yeah, okay. Okay, he said fetus. So with this, we can close the session by thanking you for this interesting and interactive and excellent presentation, Professor Hubers, and hope to see you again in face-to-face or in virtual lectures. I would like to thank the organizers, Biologics, Emirate Neurology Society, and MCO, and thank the audience, the participants, for their very fruitful questions. Thank you very much, Professor Huber.
Thank you. Thanks to the audience. Thanks for inviting me. It was a very interesting discussion for me as well. Thank you.
Thank you. Good night. Bye-bye.